Hello, good afternoon.
Hey, how you doing, Ashley?
I'm good. How are you?
Yeah, not too bad. Not too bad, thanks.
We usually start right on time, and then I'm sure more people will join as we get going.
Oh,
We are thankful for your time.
no
Uh,
worries at all. Let's see if I can doing it now. So share screen. Sorry. Um, I need to close a bunch of my tabs. Um,
Working too hard.
no, just very disorganized. Hold on 2 seconds, sorry.
There we go.
Is that showing?
Yes, we can see.
All right, cool. Um, so guys, for those of you who don't know, I'm Harry Jeyarajan. I'm one of the ENT surgeons here at UAB. I do a lot of the airway management along with my partners, Dr. Bharat Panaganti and Dr. Blake Simpson. And today I wanted to just give a sort of a brief talk on tracheostomies and particularly inpatient tracheostomies, just to give a really general overview about what they are, and what kind of things you can expect when you see tracheostomies on the floor. It's kind of very bare bones, and I would really like to just, I'm hopefully I want to get through all this stuff, and then we can just answer questions afterwards, because I think that's probably going to be the most helpful. Because I think the things that I think that may be issues may not be the same thing that you guys see as issues, and so it'd be great for me to hear what concerns you have, or problems you've had, and then I can maybe help to answer them. So just an overview of the talk. Today, we'll just talk about what a tracheostomy is, go over the very basic anatomy with performance of a tracheostomy, but also talk about the general design of the tube, just the standard tube. We'll talk about why we do tracheostomies, and we'll go very briefly over how it's performed. I was going to show a YouTube video, which hopefully will work when I get to it, just looking over one of the open techniques. And then really sort of focus later on common complications that can happen with tracheostomies, particularly the ones that are able to be managed on the floor, and we can talk about how you'd manage them, and then basically go over a very general overview of what our feelings, or what we feel is appropriate trach care in the hospital. And so these are things that when we walk into a room, we see a trach, like, right, these are basic things that have to be there. And I think it's great if everybody knows that, because it's a very easy thing to pick up and manage. And that's how you avoid most of these complications. So these are the basic learning objectives for today. All right. So first of all, what is a tracheostomy? A tracheostomy is essentially a reversible surgical airway that is positioned transcutaneously through the skin of the upper neck and entered directly into the trachea. It's usually between the second and third rings. And the reason we do that is really to avoid edema, scarring, and irritation of the subglottis, because that can make it uncomfortable for the patient, lead to constant coughing and edema, which can lead to voice changes. So this kind of airway bypasses the larynx and the pharynx, but it is reversible. What is the basic anatomy? So for those of you who know about the anatomy, I'll try and make it pretty quick, but this is just going through the layers that we go through when we do a tracheostomy. So it's nice to know when you look into a wound, what exactly has been done. So when you look at, once you pass the skin, so the epidermis and the dermis and the subq fat, the next thing you encounter is the platysmal muscle, which is the collar of muscle that surrounds the entire neck. Once you go past that, what you'll see in the midline are what we call the infrahyoid strap muscles, and usually you can see the anterior jugular veins very close to the midline on either side. Occasionally there'll be a communicating vein low down, but usually not so much. And this is important to understand this, because while it is a very, very rare cause of bleeding, that is something that can cause bleeding. And usually if it's something that's a problem, it'll be documented in the operative report. But once you pass the anterior jugular veins, you get the infrahyoid strap muscles. You get your omohyoid muscle, you get your sternohyoid muscle, and then you have your paired muscles that sit above and below the thyroid cartilage. You've got your sternothyroid muscle down low and your thyrohyoid muscle up above. And once those muscles are bypassed, now you can see the laryngotracheal framework for what it is. Here you can see the structures of the larynx here. You can see the hyoid bone here, the thyrohyoid membrane. Behind that is the epiglottis, and this is the tip of the epiglottis sticking up here. And then this is the thyroid cartilage here. And thyroid cartilage is the main predominant cartilage that houses the larynx. The vocal folds are located immediately within the confines of the thyroid cartilage. Here you can see the cricothyroid membrane with the cricothyroid muscles and the superior laryngeal nerves traveling over the muscles. And here you can see the cricoid itself. The cricoid, as you know, is the only complete ring of the trachea, and it's situated just above the first true tracheal ring, which is here. And then immediately below this and in front of the trachea, so still within the pretracheal fascia, is the thyroid gland. There you go, is the thyroid gland. And immediately behind that are the recurrent laryngeal nerves. So this is the basic anatomy of the laryngotracheal airway as you bypass all the muscles and get down to it. And like I said, classically we position the trach behind the thyroid isthmus between the second and third tracheal rings. So moving on to the anatomy of the tube. So this is the most common tube that we have in UAB at the moment. So this is a Portex tracheostomy tube. We used to use the Charlie tracheostomy tubes, and they're generally pretty similar construction, but they look a little bit different. The important things are, so here we have the tube itself. You can see it comes automatically loaded in what we call the obturator. The obturator is this purple thing here. This is essential for insertion of the tracheostomy tube. It gives rigidity to the tube itself, and it allows a tapered tip so that you don't catch on anything as you go inside. This is a cuffed tracheostomy tube, which is the most common tracheostomy tube you'll see in an acute inpatient setting. You can see this is the cuff here with a pilot balloon and a cap on the end. The cuff is a low volume, so it's a low pressure, high volume cuff. Generally, these cuffs are designed to not be inflated over 25 to 30 millimeters of mercury at all. And the reason for that is any pressure above 25 to 30 millimeters is associated with significant risk of mucosal ischemia to the lining of the trachea, which is directly related to long-term consequences such as mucosal scarring and contracture. Once the tube is inserted, the obturator is removed. Obviously, you can't really breathe through an obturator, and it is replaced by this structure here, which is the inner cannula. All acute inpatient trachs will have an inner cannula, so it's a 2-lumen system. The outer lumen is the standard trach, which sits in the lumen, and the inner cannula is removable from the outer lumen, and it's designed so that they can be removed and cleaned and put back in to prevent obstruction of the trach without having to remove the entire trach. That's particularly important for acute trachs. Occasionally, for people that have long-term trachs, you'll see that we use single lumen tracheostomy tubes. It's not that common, but we do use occasionally custom Bivona trachs, which are single lumen trachs. And again, these are only designed to be used in people that have a long-term or chronic tracheostomy tract, so that you can take out the entire tube very comfortably and put it in without risk of losing the airway. But that's not a common thing that you'll see. Moving along, this is the classic soft collar that goes around the neck and helps keep the tracheostomy in place. And this is a Passio valve, or a speaking valve. When patients have a tracheostomy tube in, particularly when they have a cuff tracheostomy tube in, they will be unable to talk because, as I said, the tube bypasses the larynx and the pharynx. So just as air goes in through the tube, bypassing the larynx and the pharynx, the air is expelled through the tube as well. So they're unable to push air past the vocal folds and voice. Now, if everything's going to plan and the patient is alert and orientated and is no longer requiring ventilation, then we can look at downsizing these larger cuffed tracheostomy tubes for ones that don't have a cuff, particularly if they're able to show that they can manage their secretions. Usually that's a downsizing event that in a very standard patient will happen at about 3 days after a cuff tracheostomy tube is placed. Now, if the patient requires prolonged ventilation, we will leave a cuff tracheostomy tube in until that is no longer required. When you downsize to a non-cuffed tracheostomy tube, it's usually a slightly smaller tube, which means there's room around the tube itself within the lumen of the trachea. And what we'll start doing then is putting this Passio valve on to the end of the trach. And what that does, it's a one-way valve. So when they breathe in, the air goes in through the valve and down through the tracheostomy tube. But when they speak, it shuts off the valve and forces air around the uncuffed tracheostomy tube up through the vocal cords so they can speak. So this allows the patient to communicate while they still have a safe airway. It is also a standard part of what most of us will use as a decannulation protocol. So before we look at removing the trach completely in a patient, we'll see whether they can tolerate a passive valve or speaking valve. Yep. So just going again now, basic principles of trach insertion and trach technique. So first of all, looking at patient selection, what are the indications for a tracheostomy tube? Broadly speaking, most of us would say that there are really three types of indications. One is an upper airway obstruction, whether that be due to a malignancy, such as a head and neck cancer patient, someone with a laryngeal cancer, or a very large pharyngeal cancer. Trauma, head and neck trauma causing significant oropharyngeal edema or soiling of the airway due to bleeding. Infection, not so much seen these days. We used to see it a lot more with supraglottitis patients that needed tracheostomies. It's rare that we use it for that now because most of the patients can be treated with either drainage of the abscess and a short period of antibiotics and don't need to get a tracheostomy tube. Bilateral vocal fold palsy, that's a common indication for tracheostomy, and obviously upper airway burns and edema. So those are the most common causes of upper airway obstruction that would lead to us considering performing a tracheostomy on someone. The other indication is poor pulmonary function. So people that need chronic or long-term respiratory or ventilatory support. So someone who is looking to need long-term airway support for over 10 days will often change an endotracheal tube for an elective tracheostomy tube. The reason we pick 10 days is we know that from older studies, and mostly in children, but some in adults, that if you have an endotracheal tube that is bypassing the larynx and is sitting there for over a period of 10 days, it's significantly associated with glottic and subglottic scarring. So in children, you classically get subglottic scarring, which leads to subglottic stenosis. And in adults, you classically get glottic level scarring, which leads to posterior glottic stenosis and fixation of the vocal folds. And while those are not life-ending complications, they are definitely preventable complications because these are often difficult to manage surgically once the patient is recovered from the acute medical illness. So placing a tracheostomy is obviously the most desired thing to do because it allows relief of pressure on the larynx itself. And finally, an inability to intubate. And so that's usually an emergency setting. So someone who comes in and they're unable to be intubated due either to trauma, bleeding, or airway soiling, or a massive tumor, we will do an awake tracheostomy in these patients because you cannot get an airway from above. What are the advantages of a tracheostomy tube? Aside from, like I said, bypassing the larynx and minimizing the risk of long-term scarring and stenosis around the larynx and particularly the glottis in adults, it often aids ventilation. It reduces the anatomic dead space by about 50%, which makes it significantly easier to ventilate someone than if they're being ventilated through an endotracheal tube. It also makes it easier to wean someone off the ventilator because it's more comfortable. So you don't have to use as much sedation in someone when they have a tracheostomy tube as opposed to when they've got an endotracheal tube in place. Those are the main advantages to transitioning from an endotracheal tube to a tracheostomy tube. Now, basic principles of dissection. In general, most of us perform tracheostomy tubes in a very similar way. There are a few differences. In general, the principles are that of a midline dissection. So you identify your landmarks, your cricoid, your thyroid notch, your sternal notch, and you stay in the midline. In general, most of us, when we go down and we identify the thyroid isthmus, most of us divide the isthmus. We used to sometimes mobilize the isthmus superiorly and inferiorly and leave it intact. The problem with that is that if a trach becomes acutely dislodged, the isthmus can block the tracheotomy, and that can make reinsertion somewhat tricky. So most of us will divide the isthmus, usually simply with Bovie cord reed. There is a slight difference in how we enter the airway in pediatric patients versus adult patients. In pediatric patients, we tend to perform a vertical tracheotomy. And the reason is because the trachea itself is very, very small and very narrow. And performing a transverse tracheotomy can often result in significant circumferential scarring in these small airways. But also, it makes it difficult to put a tube back in because you're trying to aim for a very small hole, which can be a little bit tricky in peds. By doing a vertical tracheotomy, we make it a lot easier to put a tube in. It's a lot safer because you're less likely to get circumferential scarring. And finally, it allows you to effectively use stay sutures. So when we use stay sutures, it's classically only used effectively in people that have had a vertical tracheotomy. We put sutures on either side, so usually around 1 to 2 rings on either side, and that allows you to pull the trachea out and unfold it, which allows you to immediately get access to the airway. So like I said, this is something we classically do in children. We don't really do this in adults. The only time we use a vertical incision in adults is when it's an emergency situation and you're doing what we call a slash tracheostomy. And again, that's because by doing that in a vertical dissection, staying in the midline, you can avoid injury to structures on the sides of your neck, classically the major blood vessels. Most of us will just do a simple transverse tracheotomy. So it'll just be a split between the rings. But occasionally we'll perform what we call flaps. And the most common one you'll see is a Bjork flap. And a Bjork flap is essentially, we create an inferiorly based flap that is a U-shaped flap so that the rings fold out towards the skin. The theory is if you do this, it allows you to formalize that tract a little more. It allows you to make the tract a little bit more identifiable. In reality, it doesn't always work that way because a two ring flap is very small, and particularly in our Alabama patients, usually that will barely reach the skin. The times that I will use a Bjork flap are when there's prominent vessels, such as a high-riding innominate artery, and I want to try and separate that artery from the plastic tube I'm about to put in. And so I'll often put that flap in place to prevent that innominate getting into the tracheostomy tract. And the other thing we talk about is how we secure the trachs. So classically, we'll secure the trachs. The fresh trachs will be secured in multiple ways. Most of us will use sutures through the eyes of the tracheostomy flange. So usually 4 Prolene sutures, and they'll stay intact for 3 days, as well as a soft collar that you saw before. And like I said, in pediatrics, we'll occasionally do stay sutures. Now, I want to see if I can, I'm going to stop the share for a second and see if I can share a YouTube video. If it works, great. If it doesn't, then I'll just talk you through it. Can you see this YouTube video?
Yep.
All right. So this is one of my friends in Australia who's talking
all the way down to the tracheal wall, and often a small amount of local is placed inside the trachea.
So this is talking through an open approach. So here you can see he's doing a standard approach for an adult. He's using a knife. He's cutting transversely through the skin. He's identified a position below the cricoid, usually 2 finger breadths above the sternal notch. The first thing we do is dissect transversely through the subcutaneous tissue, the subcutaneous fat, and the platysma. Once we get through the platysma, we start really doing a vertical dissection until we get to the infrahyoid strap muscles. As I said before, the infrahyoid strap muscles are separated by an avascular plane. So there's usually anterior jugular veins on the sides, but in the middle, there's usually very little vasculature. And so we identify this avascular plane, the linea alba. It's the same embryologic derivation as the linea alba in your abdomen. And it's a combination of sharp and blunt dissection. He's using largely blunt dissection. I tend to go through this with a bovie. But we dissect straight through the infrahyoid strap muscles until we get to, usually the first thing I look for, or most of us look for, is the cricoid. Remember, the cricoid is the most easily identifiable landmark in surface landmark in the trachea. And one of the reasons for this is because it's a complete ring. So when you press on the windpipe, most of the windpipe is compressible, but the cricoid is not. So it's easy to identify it as separate from the trachea. Once you get to the trachea, once you get to the cricoid, what I'll tend to do is I'll score the perichondrium and try and get underneath that subperichondrial plane onto the cartilage of the windpipe of the trachea. And that usually takes you underneath the thyroid isthmus, because the thyroid isthmus is contained within the pretracheal fascia. And you can see what he's doing now. He's bluntly dissecting between these structures here, which are the infrahyoid strap muscles there. Let's see if we can move it along a little bit. So as we get deeper in, and once we separate the infrahyoid strap muscles, we use a pair of retractors. He's using just some dull sands, but we often will use something slightly larger. What he's doing now is he's elevating the thyroid isthmus. So he's gotten underneath it with a tonsil retractor, and he's divided it with a bovichordary, and that then exposes the entire tracheal airway beneath. Once you're underneath the thyroid isthmus, there's really nothing else standing between you and the trachea. And so now he's just cleaning it up, getting hemostasis, because it is still relatively vascular, but usually it's small vessels. And now he's identifying, you can see he's clearly identified a tracheal ring. He's palpating the cricoid there. That's the first ring. And then he's going between I think he's going to go between the first and second ring. But you can see the intercartilaginous space there that he's highlighting. When we get to that point, we usually score it with some kind of cautery device. Usually I use bipolar. And the reason is because this can be a common source of bleeding once the patient's awake. So we'll score it to make sure that we minimize the risk of postoperative bleeding. Then in concert with anesthesia, what we'll do is we'll let anesthesia know that we're about to enter the airway. They'll put the cuff down on the endotracheal tube, and then we'll sharply enter with a knife and then widen those incisions, like I said, with a METS. Most of the time, we really just do a transverse incision. And so we widen those incisions, and then you can see the anesthesiologist is now pulling the endotracheal tube back. So this is an orotracheal tube. He's pulling it back until we can see below there. And now we place the cortex tracheostomy tube with the obturator into the airway. Once it's into the airway, now he's done something that we shouldn't do. He's removed the hook. We never remove the hook until we connect the circuit and the anesthesiologist tells us that they've got ventilation and end-tidal CO2. The reason being, in a skinny person, it's very easy to take it back out. If you're not in the airway, if you're false tracked, it's easy to take it back out and see the airway again. But in someone who's slightly larger, you can often, particularly in an acute situation, suddenly lose your visibility of the airway. So we'll often leave the hook in place within the airway until anesthesia tell us that they got end-tidal and they've got CO2. And that's when we'll remove the hook and secure the tracheostomy tube. And as you saw, we secure it with a series of 4 Prolene sutures and a soft collar tie. Cool. And let's stop that and go back to the showing. Check screen. Okay. So that was the surgical dissection. So how does a tracheostomy tube compare to other surgical airways? And when I talk about other surgical airways, the main one I want to talk about is the laryngectomy. In reality, there are only really 3 surgical airways that you will see: a surgical tracheostomy, a surgical cricothyroidotomy, and a laryngectomy. Here you can see a normal neck and a normal airway. You can see the tongue here. So these are all side profiles. You can see the tongue, the soft palate. This would be the pharynx. This is the larynx here. You can see the epiglottis here. You can see the hyoid here. You can see the thyroid cartilage and the cricoid, and then the upper trachea here. So this is a normal airway. You can see when people breathe, air goes in through the nose and through the mouth and passes around the epiglottis into the trachea. This is what a tracheostomy looks like. So here you can see there's an immediate fistula going between the neck skin, between the second and third tracheal rings into the trachea there. You can see airflow goes directly through this fistula into the windpipe, bypassing the larynx and the upper pharynx, but air can still travel from the nose and the mouth into the larynx and into the trachea as well, as can secretions. So this is the tracheostomy. A cricothyroidomy, for what it's worth, a cricothyroidomy is an airway placed between the thyroid cartilage and the cricoid cartilage, between the cricothyroid membrane. This is usually used in an emergency situation. And the reason is, like I said, one of the most easily identifiable landmarks in airway landmarks in an adult is the cricoid. And immediately above that, people will always be able to feel a small depression, and that's the cricothyroid membrane. So in the setting of an emergency where you cannot get an airway from above and the patient is decompensating, the safest and easiest way to get an airway is to make an incision straight through the skin, through the cricothyroid membrane. There are no vessels there that are going to get in your way. There's no thyroid, and that'll take you straight into the airway. The problem with that is it is not a sustainable airway. It's not something that can be left in a patient. One, because it's a very narrow space, so you really can't put a big tube in. And two, because it is unstable. It sits between two cartilages, one of which is circumferential and rigid. And so it's very easy for that tube to be displaced, and it's very hard to put it back in again. And it's also very uncomfortable for the patient. So it's rare that you will see an inpatient with a long-term cricothyroidomy. It's usually something you see in an emergency situation. It's something that we will always take for a formal conversion within 24 to 36 hours. So we'll formally convert that into a surgical tracheostomy. But this is what a surgical tracheostomy looks like. And to the far right, this is a laryngectomy. So here you can see there's a complete separation between the pharynx and esophagus and the windpipe. So there is no communication between the mouth and the nose and the trachea. There is a permanent, irreversible stoma or fistula between the skin of the neck and the outer environment and the windpipe or the trachea there. There is no larynx, so there's no voice box. And most importantly, this patient is not able to be intubated from above. And placing an oxygen mask on this person's mouth is not going to oxygenate the patient. And this is a really, really important distinction. This says two things. Putting an oxygen mask on this person is not going to improve their oxygenation if you put it around their mouth. And if you try and intubate from above, you're just going to go straight into the esophagus. And this is how they look in real life. So this is a laryngectomy, and this is a tracheostomy. The main differences are there's a clear tracheostomy tube in this tracheostomy patient with a soft collar strap. Here, there is no tracheostomy tube. There may be a Larry tube. This is a Larry stoma dressing. And in the distance there, you can see a tracheoesophageal speech prosthesis. This is a direct communication through a one-way valve between the back of the trachea and the esophagus, which is utilized by the patient for esophageal speech. So this is the difference between the two. So if you see someone with this and they need to be oxygenated, this is where you put the oxygen mask. And if you see someone like this, you need to know that they are not able to be intubated from the mouth or transorally. So yeah, differences between tracheostomies and a laryngectomy. Like I said, the main difference is with a laryngectomy, it's a complete separation between your mouth and your airway, and your nose and your airway, and it's an irreversible fistula. So it's not something that can be reversed. Whereas a tracheostomy potentially can be removed if the patient passes a decannulation trial and is able to now maintain their airway through their pharynx and larynx as per normal. So moving on to complications. The most common complications that we often see are infections. And really, these can be broadly categorized into two types of infections. One is at the trach site, and that usually occurs early on. It's because you have a fresh wound, it's covered in mucus and secretions, and oftentimes it's a lot of secretions that sit static in the wound. Often, like I said, it's not a sterile wound, it's a clean/contaminated wound. And if there's not appropriate care, you can often get skin breakdown and then local wound infections, especially if you get pressure sores, which then get infected. And the way we manage that is by regular care of the trach site, cleaning it every shift, suctioning the mucus and secretions, and using appropriate pressure care dressings. The next type of infection is really sort of a deeper infection, and that's associated with aspiration. So usually getting a tracheitis or a pneumonia. It's classically a later complication associated with aspiration. And that's because you've now bypassed your normal upper airway defense mechanisms by putting a tube straight into the airway. What that does is it introduces cold, dry air into the trachea and into the lungs, which causes stunning. But also the presence of the tube itself impairs the normal mucociliary function of the pseudostratified columnar epithelium of the trachea. So the trachea itself doesn't manage secretions as well as it normally would because the cilia don't work as well. And so it leaves the patients prone to excessive sputum and mucus production. And the way you manage that is by trying to facilitate humidification and warming of air, and also using regular suction and PT to get them coughing and clearing themselves. There's no other way of really managing it. If, however, they start getting or showing signs of real tracheitis, which is usually visible in endoscopic assessment as a sort of edema and an erythema of the trachea, then we will usually add antibiotics, usually ciprofloxacin, to improve cartilage penetration. But like I said, most of that infection can be managed with appropriate trach care, or prevented with appropriate trach care. The next most, well, I wouldn't say the next most common, but the next most significant trach complication is that of dislodgement. And that what that is when a trach is displaced into the pretracheal soft tissue. So here you can see a sagittal section. You can see the sternum here. You can see the rings of the trachea here. And you can see that the tube is now sitting between the trachea and the sternum in the pretracheal tissues. And this is a significant complication. This usually occurs, it's almost always seen in open trachs. It's rarely seen in percutaneous trachs. And the reason is because when you do a percutaneous trach, there's no dissection, there's no dead space for this trach, for this tube to go into. If you do get it with a perc trach, it usually implies that someone's aggressively tried to put the trach back in and completely missed. But it's not an uncommon thing to see in an open trach situation. Usually happens because the patient coughs a trach out because it's not been either secured appropriately with the trach with sutures, or the tie has gotten loose and someone's tried to put the trach back in and they've missed. Oftentimes in someone who's not ready to be decannulated, what you'll notice is the patient has, even with the trach in, they're really struggling to breathe. You'll classically try to pass a suction through and the suction will not go through. And at that point, what you have to do is really take the trach out, leave the hole open and call for help, call for ENT, or call a code to have someone, to have an airway team come and evaluate them. What I more often see is, because usually, like I said, this happens in people that it's a later complication, because usually the trach sutures have been cut and that's why the trach's able to move around. And oftentimes what I'll see is I'll get called to the bedside and a patient will be talking through their larynx with a trach tube in place and no speaking valve. So if you ever walk into a room and a patient has a trach with no speaking valve and they're talking to you, that means the trach is out. That means the trach is dislodged and it's not doing anything. And oftentimes, if that's happening, usually it implies that the patient's ready to be decannulated. But they still need to be evaluated formally. But that's an alarm bell sign. If someone's talking to you with a trach and no cap or valve, then that trach's not in the right spot. But like I said, if that happens, the thing to do is to take the trach out, leave the hole alone, and then call a code for us to come and see them. And oftentimes it requires us to come in and explore the trach at bedside. Usually we use a trach dilator, and that allows us to bypass the soft tissue tract that's been present and put the tube in place. And usually what we'll do is we'll put the tube in place and then we'll suture it back in, because we need to give that dead space that's now been created at least a few days to close back up again. Bleeding. This is probably a very common complication that makes everyone a little bit nervous. But usually early bleeding is pretty minimal in a non-anticoagulated or coagulopathic patient. It's usually from dermal vessels, usually from vessels that we've gone through in the dissection field that has spasmed closed during the operation, have now reopened again, or have opened due to just some trauma from the trach moving around. It occasionally can be from vessels around the thyroid. That's not as common, I feel, with modern techniques. I think it used to be a lot more common when people used to try and tie off the thyroid isthmus or just move it around, but that is a possibility. But in general, most of the bleeding that you'll see will be low flow venous bleeding and can usually be managed at the bedside. Most of us will come and manage this with some surgical flow with thrombin, and occasionally, particularly if you've got a dermal bleeder, we'll put a tie in it just to tie the vessel off. The most important thing I feel when you do get bleeding is you have to be meticulous about the trach suctioning and the trach care, because if they're getting bleeding and it's now going into the tracheotomy and collecting around the tube, then you'll get clots within the tracheostomy tube, and that can then lead to tube occlusion, which we'll get into in a bit as well. But always call us for this. It's usually, like I said, easy to manage at bedside because it's usually low volume bleeding. Late bleeding is a different issue altogether. Late bleeding usually occurs 1 to 2 weeks, over a week to 2 after the trach has been placed. It means that the trach wound is matured, the stoma has matured, there shouldn't be any bleeding. And so if you're getting bleeding, it's usually indicative of a deeper injury. The concern is that it often can be large volume. If it's small volume and it's coming primarily through the tube, it usually implies that the tube itself is causing injury to the tracheal mucosa. And so if it's a low volume, small amount of bleeding coming through the tube and the patient is stable, calling ENT to endoscopically evaluate is appropriate, and that's what we recommend. Because oftentimes you can go in and you'll see small bits of granulation tissue, which we can either remove, or we can usually address by adjusting the trach, changing the trach to one that fits better, and then stops the bleeding altogether. But the scary thing is when it's large volume. So if you get large volume bleeding, the immediate thing that we're all worried about is a tracheonominate fistula. And this is why you can see this is a standard tracheostomy tube. Again, this is a sagittal view, and this is the tube within the trachea. But you can see the proximity between the tube and the innominate vessel there. It's pretty close. And so there are two areas that you can get a tracheonominate fistula. The most common is through the tracheal wall, through the antetracheal wall into the innominate. And that is almost always associated with an inappropriately positioned or sized tracheostomy tube. It usually occurs in people that are not very well. So their general medical habitus is not that great. And so they're prone to getting pretty significant deep soft tissue wounds. But it's almost always because the tube is either too big or inappropriately positioned for their body habitus. And so that is one of the reasons why we push towards having smaller tracheostomy tubes if possible, rather than larger ones. If this happens, the first thing that we'll do is we will come and endoscopically evaluate. But if it's a large volume bleed, none of us want to trach that tube out, because if you do, you can precipitate a massive volume bleed that is going to immediately lose your airway. And so if at any point during the history or the endoscopic assessment, we're like, this looks concerning, the immediate steps is to establish wide bore IV access, cross-match, and get a CT, an urgent CTA. Because this is a very difficult problem to fix if it's established, and it's one that needs to be done emergently. I said before that there are two types of TI fissulas you can get. This is the most common. The other, which is less common and more associated with surgical technique, is when you have a high-riding innominate that sits up in front of the trachea and up against the tracheostomy tube here, and the barrel of the tube presses into the innominate. That's much less common. And like I said, if I see that intraoperatively, most of us will take steps to cover that innominate to prevent that from happening. From the point of view of the floor management, I don't think it makes any difference to you guys, but that's just something as an aside. Blockage. Blockage is a significant complication. It's distressing because it is easily avoided and managed, but it can be fatal to the patient. So blockage is due to an accumulation of dried sputum or crust or blood within the tube of the tracheostomy tube. Occasionally, it can be compounded by granulation at the tip of the trach, but that is not the norm, and that is not usually on its own. That's not what happens. Usually we'll go in there and we may see granulation at the tip of the trach, but it's usually on top of the fact that there's been a ton of interspiciated secretions and crust within the tube. And it's almost always avoided with appropriate trach care. The most important thing is that of humidification. So, when we have a tracheostomy tube in, we immediately bypass the normal humidification mechanisms of the nose and sinuses. And so the air that goes in is incredibly cold and dry, and it immediately causes not only ciliary paresis, like inability of the cilia to move, and so you get mucostasis, but it also causes it to immediately dry out and crust. And even with adequate humidification, that is still going to be a problem. And so to manage that, that is why we use double lumen trachs with an inner cannula. By having an inner cannula, you can remove the inner cannula, clean it separately, and put it back in. And that way you can keep the air tracts open, without having to remove the entire tracheostomy tube. And finally, suction is important. Like I said before, one of the problems that is inescapable from when you perform tracheostomy tubes is that you are going to increase the amount of mucus and sputum production just as a reaction to both the irritation of the tube and of the cold, dry air that's coming in. And so it's important to regularly suction these patients. In fact, one of the biggest problems we have in Alabama from the point of view of outpatient management is making sure that our patients get suction machines to go home with, because you can't send someone with a trach home unless they have a suction machine, because it is critical to keep that tube open and keep the patient alive. Suctioning is important, but over-aggressive suctioning can also cause problems. We generally recommend that you suction only the tube itself, and you use that in combination of encouraging the patient to cough themselves. So they cough the mucus into the trach and then they suction it out. Over-aggressive suctioning can often lead to mucosal injury, which leads to bleeding and granulation tissue formation. And late stenosis. So late stenosis is not really a problem that you should be seeing or dealing with when the patient's an inpatient. Usually this is something that happens as an outpatient. So they're discharged with a trach. And what they find is either they're unable to decannulate successfully or they're unable to voice around the trach. And what's happened is it's usually due to a combination of their general medical comorbid status. So you usually see it in people that have significant medical comorbidities, uncontrolled diabetes, people that have been very sick, that have been in ICU, that have been on ECMO. So you usually see it in those kind of patients, and it's usually a complication of the tube itself and occasionally the technique of tracheostomy insertion. And it's either due to mucosal scarring or cicatrization, or cartilaginous framework collapse, what we so call an A-frame deformity. Most of these scars, most of these late stenoses are amenable to just an outpatient endoscopic tracheoplasty. Occasionally, they need to be managed with an open tracheal resection as well. And sometimes it can lead, particularly in medically infirm patients who are not fit for a general anesthesia, it can lead to them being chronically trach dependent. So moving on to tracheostomy care. Am I going for time? Am I going okay for time, or am I overshooting it? Okay. So tracheostomy care, just a general overview. The most important, well, this is not the most important thing. I think I put it backwards, but one of the most important things about tracheostomy care is appropriate suction. Remember, even though it is not a sterile wound, it is still a clean wound. So you need to use gloves. It doesn't have to be sterile gloves, but you just need to use gloves. In general, we recommend that you advance the catheter to the tip of the tube. You don't have to go too far beyond there. And if you do have to go beyond there, you don't want to do it with your thumb on the hole, because then you'll suck onto the side wall of the tracheal mucosa and cause them to be irritated, cause them to cough, and also cause bleeding and potential granulation formation. Generally, when I do it, I ask the patient to cough as I'm suctioning to help them bring the sputum up into the trach and suction it out that way. You'll find people say that they go down and palpate the carina. I'd never recommend doing that to any of my nursing staff or any of my residents, because there's no need to do that in a patient that can cough. Humidification. So like I said, you need to make sure that any air being delivered to the tracheostomy site, to the tracheostomy, is humidified and warmed, ideally. And this has been an issue around the hospital, even on our floors, because the humidifiers can often be hooked up, but they won't actually be working. So it's important, when as part of standard trach care, to make sure with your hand that you're actually seeing humidification coming out of the actual trach collar. You can hear bubbling, but that doesn't always necessarily mean. If you don't hear bubbling, then it's definitely not working. But if you hear bubbling, it may not always mean that there's humidification coming out through there. So it's important to check it regularly when you round on the patient. You can see this is an example of a Fisher & Paykel warmer humidifier. And this is kind of the general layout. You can see it's usually a lot of tubing, and it's connected to a bag reservoir down here. And then this is connected directly to the trach. But oftentimes it'll be like a small collar that'll sit there and just open, like an open fill collar. There are ways of working around it. Sometimes using a humidifier is just not practical for the patient. And you can get HME adapters, which are basically little buttons that have a humidifier on it, and you can clip it onto the trachea, and it's a one-way onto the tracheostomy tube. And it's got a one-way valve, which also adds a humidifier onto it, so that you don't have to be hooked up to an external humidifier. They're not easy to get. But for the select patients, we can usually find those to use them. And those are ones that in general that don't have a high secretion burden, that have a mature trachostoma, and are otherwise self-caring, and can get up and walk around and can take it off and suction themselves. Those are the people that will use those HME valves on. Don't know why the suction is there, but site care is important. So generally we say you want to at least clean the trach site once a day. I generally recommend evaluating it and caring for the site once a shift. The dressing should be changed as required. It really depends a lot on how heavy the secretion burden is, which is obviously going to be higher in an acute trach and higher in someone that's got pneumonia. But as they get more mature and as they become more independent, then oftentimes there's little dressing changes required. We will often use split gauze, particularly in an acute setting. But what we're trying to do now as part of a hospital policy is begin using Duoderm around every trach site. So the Duoderm is an adhesive gel dressing that sticks to the skin around the trachostoma, and it prevents the secretions from getting in contact with the skin, but it also prevents the trach flange from causing pressure injury to the skin, particularly around the inferior aspect of the trach. And oftentimes we'll use that and then put a gauze dressing on top of that to collect the secretions. That Duoderm dressing can, if it's left unsoiled and if it's left intact, can usually be left on for about a week at a time. Inner cannula care. So we have to always ensure that there's an inner cannula in situ in the trach. And you have to always make sure that there's a spare inner cannula available in the room. The inner cannula should be changed once a shift or 3 times a day. It should be taken out, cleaned, and put back in. You can clean it with tap water, really. We don't really use sterile water. We usually use tap water. It's fine. And we usually just leave it to air dry. You'll occasionally need to use especially if it's been left, particularly if it's been left overnight. In the morning, it'd be quite heavy with crust. And if you can't clean it, then you may just have to change it out for a new one. But it's really, really important to do, because that's how you prevent tube obstructions and tracheal infections from tracheostomy care. I think that's it. That's the end of my talk. Are there any questions about what we talked about, or anything that I didn't talk about?
I think that was a really good overview for our staff, just about basics of trach. I mean, I think the occlusion is probably the biggest thing that like we run into for our, most of our patients are like chronic stable trachs. I think you touched on some of that. I mean, it's hard to know. Most of the time they've got 10 other things going on and the trach's like there. And so trying to remember to always like make sure that you can obviously look and make sure that they're on humidified air, but like finding somebody to double check that the trach care is happening, I think is kind of an afterthought when they're there for 10 other things. So
No, exactly. And then I think that's something that we are very conscious of. And that's one of the reasons why we've established a trach care team. And so that trach care team should really start in the next 2 months. And so the trach care team is I don't know if you guys know about this. It's a team of 2 APPs and an RT who will round on every single trach in the hospital. And they will make sure that all these things are taken care of. They'll make sure that the humidifier is working, that the trach site care is being adequately implemented, that the patients have all the things that they need in the room. And they'll also be responsible for nurse education on the floors that look after trachs. It'll be linked to my consult team. So if there's anything that's particularly concerning, I'll be notified. So the trach team rounds independently every day and then finds me usually around midday and lets me know of any ones that they want me to look at, and then I'll go and see them myself. And this is an effort to standardize trach care in the hospital, but also, like you said, this is only a small part of what a lot of you guys are looking after the patient for. And it can often fall under by the wayside. And even for our patients, the amount of times I've come to see my head and neck cancer patients on the floor on a weekend and gone, man, versus the head and neck floor, and the trach is occluded. And I've even had to take a patient to the OR because the trach was occluded so badly because they didn't get trachea overnight. And so the function of the trach team is to make this not a problem for anyone else, to standardize the care and make sure that no one else has to really worry about it too much.
Yes, I knew that was coming. I wasn't sure if it had actually started yet with the details of
Yeah,
it.
no,
Helpful.
yeah, no, it hasn't started yet. We've hired the 2 APPs, and I think we've hired I think we've narrowed down the RTs. I don't know if we've hired them yet. I know that on my calendar is like a bunch of interviews. I don't know whether it's just to rubber stamp it or whether we still need to hire we still need to hire the RT. But it should be happening sometime in the next few months. Like the original rollout was meant to be August, September. So I think that's probably still on track to September.
That's fantastic. That will be great. I think Chanel, you have a question?
Hi, yes, sorry. Just real quick. I had a patient last week that had a trach. So when this team is rolled out, if we're having issues with a patient that has an established trach, are we allowed, if they're not already on board, say, hey, I have a couple questions about this, trach, can you come by and look at it? Or
Yep.
If they're having like copious secretions, like, do you have any recommendations on how to kind of thin these out or anything like that? Like can we kind of like, I wouldn't say like curbside, but just kind of like reach out to see if they could possibly help if we're having issues with a patient that has an established trach for a while.
Yes, definitely. That's their job. Their job is not just to look at acute trachs. The job of the trach team is to see literally every tracheostomy tube. Every patient has a tracheostomy tube in the hospital, whether it's an acute trach, a well-established trach, even like it's their job also to establish to help supervise and establish decannulation protocols, even after the trach is removed, to review the patient and make sure that they're doing okay. Yeah, they're there to support all the teams with any questions, with any kind of trach.
Thank you.
Does anybody else have any other questions?
Yeah, I just had a question. I'm assuming that's something different than obviously the airway team that we would call if the trach fell out and we're having difficulties with RT getting it back in or anything like that, correct?
Yeah, it's a different team. So if you have a trach come out and the patient has an airway emergency, you call the airway team. And the reason is because the trach team still works basically like I don't know what the exact hours are, whether it's 6 to 4 or 8, I don't know, but it's daylight hours, so they're not there after hours. And so when we formed the team to avoid confusion, what we wanted was to say, if you have an airway problem, you call the airway team. Now, if it's within hours, the trach team hopefully will come as well, really just to provide support. But their main goal is stable trach care rather than emergent care. Any other questions? Is the trach team available at night? No, so only during the day. And so at nighttime, like I said, at nighttime we do have, so at nighttime so the hope is that outside of emergencies, with having a daily rounding trach team, you shouldn't have too many questions for a trach team at nighttime outside of an emergency, at which point you'll call the airway team. But we do have an ENT resident. So there's an ENT resident on call who basically covers for the trach team. Let's say, for example, a patient comes in overnight. It's a brand new patient. They come into the ER. They've got a trach. They haven't been seen by the trach team because, they came in overnight. Patient comes in with some god-awful broken trach with no inner cannula, then call the ENT resident. Yeah. Any other questions?
Well, Harry, that was fantastic. So we'll upload this to we kind of save all these and put them on for the share drive for folks who couldn't be here. If we have any follow-up questions, I'll be sure to send them to you. Thank you for taking an hour out of your afternoon to come and spend it with us.
Absolutely. No worries. Thank you so much. And like I said, I'm happy to take any questions later on as well.
All right. Thank you so much.
Thanks, guys. Bye.
Bye.